joint briefing with the Appropriations Subcommittee on Health and Social Services, as well as the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of their slides. Before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let committee staff know and we will send you a copy. Please note that food and beverages are not permitted in the galley. You will see delegates may have drinks at their desks as meetings can run long and hydration is necessary. If a member is not present in the gallery, please understand that they may be attending other official meetings while remaining informed of our proceedings. Please adhere to our usual committee rules of 1 question and 1 answer from the panel, not 1 question and 1 answer from each panelist. And please keep your questions brief if your questions can be shorter than the answers. I will also try to remind myself, because I'll admit, I'm pretty excited about this briefing. Please keep in mind this briefing is scheduled to conclude at 2 p.m. And with that, we are going to start the briefing from the Commission on Public Health with our Commission on Public Health, the Maryland Department of Health, followed by our legislative initiatives with our good partner from across the street, Senator Clarence Lamb. So Commissioners, Brewster, Lashniak, and Olateju, you are welcome to our committee, and it is just a joy to see you all again.
Great. Thank you so much. And I will start. My name is Boris Lushniak. I'm the Dean of the School of Public Health at the University of Maryland in College Park. Go Terps, fear the turtle. That being said, I bring to you a brief briefing on 2+ years of work. We are the 3 co-chairs of the Commission on Public Health. Madam Chair was also a member of that commission, as was Senator Lamb. Over the course of those 2+ years, we ultimately came up with a final report that you have in front of you. And the real key feature here is building the future of Maryland public health. It's basically looking at both lessons learned throughout our history, most specifically over the COVID years, but also looking at what works in the state of Maryland and what doesn't when we provide that essential service to our population, the public's health, a key feature. Next slide, please. So with today's overview, I will start briefly on the purpose and vision. We'll talk about process, findings, and recommendations, and then we'll conclude with next steps. Next slide. This is a quote from a report. The time has never been more urgent to recognize that public health as a fundamental driver of social and economic productivity. So the health of our population matters not only for that individual, it matters for that family unit, it matters for that community, but also it matters for the well-being of our counties, our state, our nation, and yes, the globe. Next slide. The Commission on Public Health was established by the Maryland Legislature, House Bill 214, signed into law by Governor Moore in June of 2023. And the legislation called for 3 co-chairs who are here in front of you, 16 members with specified backgrounds. And subsequently, there was a Senate Bill 281 that extended the commission until June 30th, 2026. So officially we'll be sunsetting this coming summer. Next slide. When we talk about the purpose of this commission, it was to make recommendations to improve the delivery of foundational public health services in Maryland. We believe that a healthy and thriving Maryland where every community flourishes with equitable access to comprehensive public health services, empowering everyone to achieve well-being and improved health outcomes is our vision. Next slide. This is a slide that talks about the capabilities of public health, the essential public health foundational capabilities, and ultimately the impacts of that. We talk about foundational capabilities, the workforce, the governance, the leadership, the funding, the various groups we had within our commission structure. We talk about the services that are offered there to our population, and ultimately the positive impacts that come from that, which include smarter resource allocation, population health improvements, economic growth, and better quality of life. Next slide. Public health is everywhere and impacts us all. Maryland has dedicated governmental leaders and a multidisciplinary workforce working with partners to tackle the health and healthcare challenge of our communities. A primary goal of public health is to prevent diseases before they start or before they get worse. And this creates linkages to social services and to our traditional healthcare service delivery system. Clean air, clean water, a healthy environment is essential to public health. Our public health policies include monitoring the environment and keeping it safe, and our public health system protects and promotes the health throughout the life stages of that individual, their family units, and their communities. What children learn early can keep them healthy throughout their life, and many are needed to become future public health leaders. That's part of our job in the world of academia. Next slide. I'll hand over the process to my co-chair.
Thank you, Dr. Lushniak. Hello, everyone. My name is Dr. Oluwatosin Olateju, one of the commission co-chairs, HPC representative from Coppin State University and Morgan State University. It's such an honor. I want to take this opportunity to once again thank the House Health Committee and the Committee on Health Social Subcommittees. Thank you so much for the opportunity to present this report. The Commission's authorizing legislation back in 2023.
Dr. Olateju, can you just move the mic a little closer to
Okay,
yourself?
I'm sorry. Can you hear louder now? Okay, awesome. Thank you. So the Commission's authorizing legislation included the Public Health Accreditation Board's foundational public health areas and capabilities as a guide to support our work as a Commission, and which established the work groups that you can see on the screen here that encompasses the governance and organizational capabilities, funding, workforce, data and IT, and communications and public engagement. The Commission organized its work into these 5 focus groups to ensure an in-depth, expert-driven analysis across all public health infrastructural areas. And the Commission also incorporated a 6th legislation topic, which is procurement. All that are essential building blocks for a strong public health system. Now, the 5 expert work groups encompassed over 100 members that were led by the work group co-chairs. The work groups met regularly to review evidence, to identify gaps, and shape draft recommendations that informed the final report you have right before you. Over the 2 years of our work, the Commission held 26 public meetings that were hybrid since December 2023. Each meeting was open to the public. It was recorded. It was posted online. The 3 Commission co-chairs met at least once every week, and we arranged guest speakers across the nation. And all of these further guided our discussions on the topics that you see highlighted in the statutes and the report. Now, next slide, please. The slide you see here shows a pictorial graph of Maryland, of the different counties here. Our process was deeply grounded in a statewide understanding of Maryland's public health system, engaging the Department of Health and all the local health departments. This statewide lens informed where the systems are working, where there were strains, and where improvements were needed before we could come up with a meaningful recommendation. Our academic partners included the University of Maryland School of Public Health, like I said, Morgan State and Coppin State. They played a vital role in designing, conducting, and analyzing our comprehensive statewide assessment. They also provided interns who served as support staff across the work groups and helped with the Commission leadership efforts. Additionally, the Dearborn Foundation conducted a focus group of all the local health officers on the topic of workforce, and this included 100% of local health departments. I'm going to repeat that, 100% participation from all the 24 local departments. Also, the Commission received support from philanthropic organizations, including CDC Foundation. It's important to note this. While our task was rigorous, the work was undertaken pursuant to a guiding principle of active listening, deep engagements, and transparent leadership. Next slide, please. As you can see here, we listened and learned from not only the public, but also governmental entities. and our work was immersed in health and healthcare and well-being. To carry out our charge, the Commission employed a systematic, multi-layered approach and integrated data and community input. We started with the development of an evidence-based public health conceptual model, and this guided all the phases of our work. The approach was further supported by an assessment framework, and we used various tools to gather the data. As you can see here, the tools encompass surveys, key informant interviews, focus groups, site visits, public listening sessions, and public comments. The tools help to further foster inclusive engagement. And as we continued our work, we stayed true to the core values that the Commission coined. And these core values were communication, equity, inclusion, and innovation. Those values not just shaped what we studied, but how we listened. And we used a community-informed process throughout, which reflects thousands of voices across Maryland. I'll now pass it on to my co-chair, Mina. Thank you so much.
Thank you. Good afternoon. Thank you so much for the opportunity to be here and to talk about the work of the Commission on Public Health. Chair Bagnall, thank you very much for all your amazing, amazing work on the Commission alongside Senator Lamb. And thank you also for having us here today. Vice Chair Cullison, it's good to see you as well. I wanted to talk about the recommendations from a broad lens. All of you have reports and executive summaries in front of you with more detail for each of these recommendations that I'll try to describe at a broad level. I'm Mina Brewster. I'm the County Health Officer in St. Mary's County. I've been there for over 13 years. And so as I'm talking about these recommendations, I will certainly make a few comments here and there about how this is relevant to local health departments and local communities in Maryland. I know Deputy Secretary Sullivan will be speaking later about the state perspective. Essentially, there are 5 themes of the 62 or so recommendation that the Commission has put forward, which are all listed in your final report. These 5 themes are all about strengthening what works, not rebuilding the entire system of public health in Maryland. We have wonderful system partners in the state who are doing great work. We have many opportunities to improve upon this great work, though. The Commission's recommendations fall into these 5 clear themes. They are practical, they're focused on execution, and across all 5, local health departments do play a central role, as does the State Health Department. As you know, local health departments are delivering results closest to Marylanders in our 24 jurisdictions. But these themes are all about making Maryland's shared state and local system work better, faster, and more efficiently. I'll start with the first theme, which is strengthening public health infrastructure. Infrastructure is about capacity, not bureaucracy. It doesn't mean buildings, although these are very important to the work that we do in communities. It means leadership, funding, and people. Health departments already seek to operate efficiently, but outdated systems slow us down. Strengthening infrastructure allows state and local health departments to respond quickly to needs that arise in the state and at local community levels. In particular, let's talk about leadership and governance. And the core message here is that alignment improves speed and accountability when it comes to leadership and governance. Maryland has a shared governance model. This is a strength. It does need better alignment, and the recommendations of the Commission go into specifics as to what could be done to improve alignment between local and state. Clarifying roles is one of those, clarifying the roles between state and local levels to help reduce confusion. And also, when communication is strengthened between local and state, we can act more in that alignment. Equity impacts assessments are listed here to help ensure that policies work for all counties and Baltimore City. We certainly want to make sure, and the Commission's report did highlight the disparate impact on rural counties as well in Maryland. And we want to make sure that rural counties are also reflected well in the policies of public health policies for Maryland. The next is human resources as part of that strengthening of infrastructure. And I think we all probably can agree or recognize that the workforce is the backbone of our public health system here in Maryland and across the country. Public health outcomes depend upon people, not just plans. And the state and local health departments often are challenged by outdated HR systems or slow hiring and challenges with retention that make it difficult for us to be a strong backbone for the public health system. Modern HR processes mean faster hiring, less turnover, more continuity of services, and protecting the existing workforce is more cost-effective than rebuilding after losses. So a strong state and local public health workforce will lead to innovation, where public and private sector partners collaborate better together and we nurture creative ideas. This is when Maryland becomes a national leader. Lastly, on infrastructure, the topic of funding. Funding mechanisms really haven't kept pace with how public health operates today. The Commission recommends modernizing funding structures to more accurately reflect the critical and complex roles of modern-day public health. Targeted investments, in particular in communication, technology, and health needs assessment, have statewide benefit. Local health departments already work to stretch every dollar we can in our communities because we know our communities really well, but additional support will help us be more efficient and address all the gaps in care in our community levels. The next theme is about modernizing and maximizing public engagement, communications, data, and information technology tools. In public health, trust and data are essentially force multipliers. And health departments at state and local levels lack modern tools in many cases to effectively optimize our efforts around public engagement, communication, and IT. Clear communication with our public, with our partners, across each other, improves compliance, it reduces misinformation, and it saves money long-term. Shared data and IT systems reduce duplication across counties and the state. And ultimately, this is about making informed decisions faster, especially during crises. The next theme is leverage and formalize partnerships. I think no time illustrated it to us better than I think over the past 5 years or any time we face unprecedented crises in communities and in public health. But the public health succeeds through collaboration. And government, while the focus of this commission was to evaluate the governmental public health infrastructure, it was a core focus of this commission, government cannot and should not do the work alone. And local health departments, the state health department, we already partner with hospitals, nonprofits, academias, and businesses. There are opportunities to strengthen this that the Commission's report highlights. Formalizing these partnerships reduces redundancies while maximizing impact. And this approach will also strengthen local innovation while maintaining statewide consistency. The next theme is about bridging public health and healthcare delivery. Ultimately, prevention and care must work together. Healthcare treats illnesses, public health prevents them and mitigates the impact on families and community of these illnesses. Local health departments already connect residents to care, especially in underserved area, but better integration between public health and healthcare system partners can reduce avoidable hospitalizations and long-term costs associated with poor health. Clarifying public health's role also helps all of you in the legislature, as well as our local leaders, understand where the investments in public health are paying off. Lastly, although certainly was a core feature of our recommendations from the Commission, is our workforce, paving the way for our current and future public health leaders. Workforce development is both effective practice as well as a long-term cost containment strategy. And Maryland really needs a sustained pipeline of public health leaders. Local health departments can serve as training grounds for professionals of all different kinds. We often have working for our agencies from behavioral health professionals to healthcare providers like nurses and physicians to social workers, program managers, data, communications, a whole array of workforce qualifications and experience functioning at local health departments and also at the state. Investing, though, in education and service opportunities will strengthen both state and local capacity. All of this is about continuity, readiness, and institutional knowledge. The recommendations that the commission focused upon were all intended to improve health outcomes for Marylanders across the state. The investments associated with these recommendations will drive measurable results and improved health and wellness of Marylanders. The commission's identified core investments will directly lead to these outcomes. And local execution of public health programs and services with state support will deliver the strongest return on the investment. So really, this is a strategic opportunity for Maryland. The recommendations from the Commission on Public Health, acting on these recommendations will improve the health preparedness and economic prosperity for the state. Maryland can lead nationally. We're already positioned to be a national leader in the realm of public health and healthcare. And investing in these recommendations, implementation of these recommendations, the Commission feels is an investment in Marylanders, in local communities, as well as the state's overall future. Of course.
That concludes our briefing, and we're willing to take questions depending on our time factor.
So if I can ask for you to stay, because I know that the department's going to talk about the walk, the crosswalk that they've done, and then our good friend and partner across the street is going to talk about some of the initiatives that we're considering. So I think we may have more questions as we build on. Thank you so much. And if I can invite Assistant Secretary Crom, Deputy Secretary Sullivan to the table, and you can talk to us about the work of the department in collaboration with the Commission on Public Health.
Thank you so much. First, good afternoon, everyone. And in particular, Chair Bagnall, thank you for all of your work and everything that you're doing. Vice Chair Collison, it's wonderful to see you. Chair Shetty, all of the other committee members and delegates, thank you for having us here today. My name is Dr. Meg Sullivan, and I am currently serving as the Deputy Secretary for Public Health Services at the Maryland Department of Health.
Good afternoon. Good afternoon, Chair Bagnall, Vice Chair Collison, Chair Shetty, and members of both committees. I'm Elizabeth Crom, and I'm the Assistant Secretary for Population Health and Strategic Initiatives with the department.
So first, on behalf of the Maryland Department of Health, we both want to extend our sincere appreciation to the Commission members for their dedication and efforts on the assessment of our public health system's foundational capabilities and their recommendations for continued improvement. And I think we can unequivocally say that we share the Commission's goals to enhance the foundational capabilities across the department and to improve health for all Marylanders. We have collaborated over the last year on commission assessments, work group meetings, regular check-ins, and can also say that in so many meetings that we're having, whether it's within the health department or with stakeholders, the Commission on Public Health report is front and center and will continue to be for so many of our conversations. This, just to really reiterate that the recommendations put forward by this commission are truly a testament to the vision, dedication, and collective expertise that guide our work in Maryland. I do think that we need to note that we are mindful of broader fiscal challenges and uncertainties in public health, which really do call for thoughtful planning and alignment of resources as we look at each of these recommendations in detail. But we truly do look forward to working together on this in a way that provides the greatest impact as we continue to support the health and well-being of our communities. As this is just another graphic, you heard from our commission co-chairs about the report themes that the commission work group did, and I won't talk through these in detail, but what I will say is this aligns so much with the work that the department is doing, and what we want to do during our time here is really just spend a couple of minutes briefly highlighting some of the work that the Maryland Department of Health has been doing and plans to do that are aligned with in response to the commission recommendations. This is in no way a comprehensive of all of the work we're doing, but thought we'd just take a time to highlight a few of those key themes. So first, the first theme around strengthening infrastructure. We have made and really continue to make progress in building our public health infrastructure, particularly leveraging our Public Health Infrastructure Grant, or FIG funding, that has allowed us to enhance workforce development, foundational capabilities, and data modernization across MDH. Again, such central themes that we see in the commission report as well. As you can see on this slide, some of the highlights that we've been able to do include launching our first apprenticeships and certificate programs, which we'll talk about a little later, enhancing communication capabilities, and strengthening community health services, including youth engagement, mobile outreach, and so much more.
And I think with this, one thing I'll add is, and the great thing about having this report and having the close relationship with the leadership from the commission is that we brought all this forward with new opportunities. So when we were putting together our rural health transformation program, we looked to recommendations from the Commission on Public Health to see what we could include. That led to us actually taking on one of the recommendations that's related to billing and helping our local health departments, our local areas on aging, our local behavioral health authorities that are providing essential services who sometimes struggle with billing and empanelment with insurance. We're actually funding that work through the Rural Health Transformation Program to help support the billing work.
Wonderful. Just continuing on the theme of strengthening infrastructure, as somebody who has experience working in local public health and understanding truly how critical the work that local health departments do every single day, engaging health officers and local health departments has been and will continue to be a top priority for us. We have really been working and again using the Commission on Public Health, some of those underlying goals and strategies to thoughtfully make sure that we are engaging health officers by launching a new health officer onboarding guide for new and current health officers, really listening and implementing recommended changes, whether it's during our monthly health officer meetings where so much valuable conversation happens, or improving our processes for communications, making sure that their voices are at the table and front and center of the work that we're doing and every decision we're made. And this is something that we really look forward to continuing. Going into theme 2 around modernizing and maximizing public engagement, communication, data, and information technology tools, again, could not emphasize enough how much we appreciate the focus on modernization, particularly when it comes to data, and really have tried to both be very thoughtful and deliberative around stakeholder engagement. You can see on this slide just a few examples of that, but also focus on making sure that we have data that is accessible to the public, especially through the ways of interactive dashboards, by making dashboards available on high priority topics, including maternal health, including overdose, biosurveillance, respiratory illnesses, with a focus on increased data transparency and data access. And we're really committed to continuing to build upon these to incorporate key feedback from our stakeholders, including local health departments, and build upon this more.
And when we think about our state health improvement plan, the measures that are a part of our AHEAD model, so the state's model payment program, this is all added then into these interactive dashboards with the ability to drill down. So we think about our local health officers as the key health strategists, right, for their communities, having the ability to look at community-specific conditions and drill down in these areas. We've been able to do through the data office, trying to connect data across sectors and then be able to put it out in usable ways for both programmatic work and then policy and assessment.
We look at theme 3, leveraging partnerships. We've already touched on this a little bit, but again, cannot emphasize enough how much of a priority this is for us. So from just on this slide, just a few examples in our maternal child health work, in our Women's Health Action Plan, partners like the Birth Equity Funders Collaborative and Upstream USA. Our Behavioral Health Administration has worked with key partners, including the Trevor Project, and then making sure that we're developing new partnerships, including with Bowie State, which is developing a project management certificate program for employees, and again, also looking for other opportunities, including a business roundtable, which my colleague will talk about.
Right. This is another specific recommendation from the commission, and so we agree we should have a better relationship and connection to the business community. So our planning will begin in the last 2 quarters of this fiscal year with the goal of actually launching that business roundtable on health in state fiscal year 27. So the next theme is around linking, the public health side to the healthcare delivery system. And I think 2 main examples here are our AHEAD model and then also the Rural Health Transformation Program. And again, this is really where we have gone and tapped into the local expertise that are within our local health officers and tried to really make their input and decision-making a part of how we built out programming. Throughout all of the work with the AHEAD model on the population health side, we worked with a subgroup of health officers on how to design these population health accountability plans that link up to our state measures. With the Rural Health Transformation Program, we're putting local health departments at the center of a lot of our grant making. If you think about mobile health, which is in our innovative care bucket, that is going directly to health departments, and they're going to decide how to build out mobile health in their communities. So we're really trying to lean into what was recommended by the commission around the local chief health strategist role for these local health officers and building from the community. The other piece is workforce, and that really building out the workforce side, which I know we'll talk a little more about later.
Wonderful. And finally, theme 5, future public health leaders. Again, I know one of our commission co-chairs mentioned really the report is about building a future of public health that starts with workforce and that starts with new public health leaders. So just as some examples as ways that we have been trying to pave the way for future public health leaders, not just in Maryland, but in our regions and in governmental public health, we launched a paid public health internship program in 2022, and thus far have hosted over 250 paid interns. Last year, we launched the first in the nation environmental health apprenticeship program, leveraging federal public health infrastructure grant funds that I referenced earlier. And what's exciting about this program is after successfully completing the apprenticeship, the apprentices will be a licensed environmental health specialist and will work in a local health department where we know there is such a critical need and how important that work do. They play such a critical role in protecting public health and the environment, from keeping our food safe to controlling the mosquito population to really so much more. We're grateful to the multi-agency coalition that worked with us to build this program, including Morgan State, the Department of Budget and Management, the Department of the Environment, and the Maryland Employees Professional Council.
And then I know we cornered Boris just a little earlier to catch up on this, but we do have plans, and again, another recommendation from the commission to build out, what is known as an academic public health department. So the planning, again, these last 2 quarters of this fiscal year with the launch by early in 27. And then for a rural health transformation program, there was a recommendation from the commission about a public health core, a public health service core. We have the dollars, we put the dollars in to build it, so we'll be working with the Department of Service and Civic Innovation, DSCI, to actually put that together. And that, when we think about workforce, while we're using and leveraging rural health dollars, we're trying to be comprehensive about the health workforce, not just health care. So really everything from community health workers, peers, digital navigators, all the way and up through and including clinical and advanced practice providers.
So that was just a brief snapshot of some of the work. Really want to say thank you again to the Commission on Public Health for conducting such a thoughtful process of assessing needs and engaging communities across Maryland, and of course for allowing MDH to be a part of it and continue to be a part of it. We can say that we have made tremendous progress, but we know that we have a long way to go, and we share that urgency that we heard from our commission co-chairs. We share the goal of strengthening what works, but looking to the future, being innovative, and really focusing on, again, building the future of public health. And more than anything, we look forward to continuing to work in collaboration with our partners, with all of you, to further prioritize our resources and efforts and move this work forward. So thank you very much, and we look forward to questions whenever that time may be.
Thank you so much, and I'm going to make the same ask because now we're going to hear from Senator Lamb, who was also a member of the commission and saw this good work and is working on the legislative considerations for how we ensure that we continue moving this work forward. Thank you so much, and welcome to our committee. I didn't expect to be in this seat when you came. So. It's very good to see you.
Very good to see you in that seat. Very good to see our former Madam Chair, now as Madam Speaker. So I know she's been very involved in this and certainly appreciate her leadership in this over the last 3 years and yours as well, where you've been able to serve on the commission itself for the last 2 years. I know you've put a lot of time and effort and thought into the process. I think both of us, and I guess in some ways, since we were both part of the commission as members, I'll speak on behalf of both of us to extend our appreciation, of course, to the commission co-chairs for all of the time and effort that's been put into this. It's been a body of work that has been a labor of love that really demonstrates the value and the time, talent, and effort that so many Marylanders invest in our public health infrastructure here, and recognize that there's still a lot of work to do. We start from a good place. We start with a good heart, but we want to keep pushing to be able to advance to support our public health infrastructure as much as we can. So I think on behalf of our legislative designees, thank you to this as well, and also to the speaker, who has put a lot of her effort and attention to this as well. She came out to the press conference that the commission had back in November to be able to really kick off a lot of these recommendations and put them forward. And I know this commission is very near and dear to her heart, and the effort that has been undertaken as well. So I'll be very brief because I think the commission has gone through a lot of the high-level recommendations and also the process. And we will say that on our behalf, again, it was a very comprehensive process that they went through. That Delegate now Chair Bagnall also participate with meetings throughout the state. And hearing from many different stakeholders, had a very structured process to solicit public feedback and input, and that was incorporated into this report as well. And so there will be legislation that the chair and I have worked on to at least move some of the recommendations into legislation and potentially into statute. And I think the approach that we took to this was to first look at some of the lower hanging fruit, some of the easier, so to speak, recommendations that were probably less complicated and more straightforward to be able to put together into legislative language. There was also an intention to really look at infrastructure building, that this is, we're trying to put the pieces in place, the building blocks in place to have a good foundation from which further action can take place later. And so some of the components of this legislation are really infrastructure building as well. And to recognize that this is a multi-year process. And I think both the commission, the co-chairs, the chair of this committee obviously recognize that this is just a starting point, that that when it comes to implementation with the recommendations, it's going to take some time to work together with the department and applaud their efforts as a starting point as well to be able to continue to advance the recommendations here. So, at a high level, those are the intentions of this. We recognize as well that some of this requires statutory change. which is why even though, I think there's been a lot of progress made, a lot of progress being highlighted by the commission, department undertaking a lot of good efforts, there are things that do require statutory changes. Number two, having things in statute also provides for longevity and also sustainability of these recommendations, which we think is also important. And then also, the commission and its intention is to help with implementation as well. That, while there's a lot of fact-finding and compilation and distillation of important findings and conclusions as part of this effort, implementation is incredibly important because we don't want to just have a report that sits on the shelf. And so what we're seeing here is that next phase of implementation. I think the commission went through a lot of the high-level recommendations and why this bill really matters. I think there's a lot that we can build from a really strong public health infrastructure and department and local health departments coming out of a pandemic, but there's also a lot that we recognize that can be done. And so along those lines, when it comes to the commission itself, we do not, I guess as a preface to this, we don't have language from the bill yet. I know the chair and I were meeting as recently as just a couple weeks ago to be able to craft together legislative recommendations. That is still in drafting. Hopefully should be back sometime this week so we can drop it in the hopper on Monday, at least on the Senate side. And we will certainly share that with the committee once we have that as well. So we want to get that language to you, but we don't have it currently. So I'm going through a very high level of those recommendations. When it comes to implementation, I think we recognize that it was important to be able to have the commission continue to work on implementation because the expertise is here with the chairs, the commissioners themselves to be able to help advance this in a way that's productive and follows the vision of the commission. And so the intention here is to extend the work of the commission. It was set to expire in 2026, later this year, but to help bring the stakeholders together and also to reformulate the membership of the commission to really focus on implementation. And so there are some membership changes here and also some continued reporting back to the legislature on progress that's being made as part of this ongoing work. That should read January 1st, 2028. And those members, I think, really helps bring together the necessary stakeholders in various different departments to make this happen. That we recognize that earlier this was fact-finding, now it's really trying to bring those parties into the room that can help drive solutions. And so that's why we have updated this committee membership, this commission membership with what you see there. There'll continue to be representatives from the legislature as well as local health departments and health officers and the public as well. And so the bill, once you have it in your hand, will extend the charge and the mission of the commission and also kind of tweak the commission's mission to focus on implementation. Those who are members can still remain in their seats unless they step down. And this is intended to help provide some continuity with the work that's being done. What you heard from the commission co-chairs earlier was some ability to have local health departments have additional flexibility and also responsiveness. And so what the legislation is proposing to do is give a little bit more effort to local health officers in their ability to hire individuals within their local health departments to be a little bit more nimble and responsive. And we know that there's been certain challenges in getting through kind of the bureaucratic process of getting folks hired. We're hoping to streamline that. We're hoping to work through with various departments, including DBM and MDH, to make that work. That's why they're part of this ongoing commission work as well. They also identified, as you may have heard earlier, that when it comes to certain things like procurements, particularly with like electronic medical records and electronic health records, there is an ability to be able to pull resources together to find efficiencies there to make it less expensive if you're able to come together as various local health departments to make that work. So that's also included as part of the bill. Workforce was obviously an important component of this. And so this is an infrastructure building piece where it was a building block to create a public health workforce development fund. There is no funding that's explicitly going into this. This is really just to set that up for future opportunities to look at how we can expand our public health workforce. We know, this committee knows, that there's a shortage of healthcare workers workers. There's also a shortage of public health workers to be able to support our local health departments, the local health departments in your districts, to be able to do everything from animal control to noise and to environmental health and sanitation work. So that's really important to help support that as well. There may be opportunities to support that fund out of the Public Health Improvement Fund, out of the HSCRC. That will all be kind of spelled out, but again, no current dollars go to that effort. It's really just putting a building block in there. There is also intention for greater collaboration with the Maryland Department of Civil Service and Civic Innovation. They have a Maryland Core Advisory Board looking to be able to add a health officer to that. You're familiar with our fiscal notes. There's a desire by the commission to have the Department of Legislative Services look at how there could be health equity impact considerations as part of legislation as well. This is not to require it. This is really just to have DLS look at whether this is even potentially feasible. There was also a desire and a specific recommendation out of the commission to update the language of the Maryland Medical Reserve Corps to change their title and also to broaden kind of their purview to bring in additional public health and healthcare and non-clinical responders to help respond to any public health crises that we may have. So that's incorporated as part of this as well. So, you know, once we have legislation firmly in hand, we're happy to share it with all of you. I know the chair is familiar with these as well. Again, this is just a starting point. We're certainly open to input. We recognize this is a multi-year effort, so there will be more to come. And happy to take any questions along with the rest of the panelists that were here before. Anything you want to add, Madam Chair, to this?
No, I really appreciate our partnership, and I know that, you know, this is still in process, but this was even addressing which recommendations we were going to try and tackle legislatively was an ongoing collaborative conversation, so I just really appreciate the work. I'm going to open it up for questions. I'm just looking to our amazing counterparts in appropriations if there are questions from appropriations. And if not, then let me start with Delegate Rosenberg, followed by Madam Vice Chair, followed by Delegate Kaufman.
I would say that of all the issues I've worked on over the years, and as this committee knows, that's 44 years, the one issue that means the most to me is helping people go into public service who have a debt, an academic debt. And we first did that with lawyers, have expanded it to doctors and nurses. So I very much am excited, very excited about the public health workforce development and look forward to working with you to make it a reality and then to get it funded. So thank you. Yes, thank you. Oh, thank you.
And wholeheartedly agree with you. I think as just a very small example, and this is the top leadership, obviously, of your local health departments, but I think in the last probably 3 or 4 years since the pandemic started, the local health officers across the state, we've lost probably about 10, right? So that's a lot of years of experience from retirements, attrition, folks leaving, you know, transitioning out to different roles. You know, over 10, I think, out of 23 jurisdictions have health officers who have changed over. And that's just a snapshot at the very top. That's, you know, reflective of what you see within local health departments themselves.
And I didn't do a good job of welcoming all of our panelists back to the table, because as we said, this has been a very collaborative process. So, and I'm going to go to Vice Chair Cullison.
Thank you, Madam Chair. And I want to offer my most sincere thanks to the Commission and the work that you're doing. I mean, this is, as my colleague to my left just said, this is like one of the most important things we can do for the residents of our state, is to make sure that they have the health care that they need. I guess my question is for whomever would like to respond, but in terms of the kinds of programs that you've built around collaboration, community building, public input that you're recommending, I think all of those are stellar. One of the things that sort of got glossed over is funding. And so I know you know that the budget now we are in a bit of a struggle with, so there probably isn't a lot of funding that we can put into these efforts right away. However, one of the things I always encourage our agencies to do is to look for efficiencies and look for ways that funding can be realigned to meet new goals. I mean, and let's be clear, these are newly developed and, being fleshed out goals that we have. But one of the things that's come clear to me in the last couple of years is that we don't maximize our federal dollars, and that we actually lose federal dollars in any given year. And I think some of that is, there are systems in place that contribute to that, but I am becoming more and more aware of the technology systems not keeping up with that. So I'm wondering if there were any discussions around this, or there's advocacy for upgrading our technology systems that relate directly to the federal government, that allow for the flow of federal dollars to come back to us in a much more efficient way. Did you have those conversations? Did you have any specific recommendations about that? I think, yes, the Commissioner.
I'm happy to start, and I think it would be great also if Deputy Secretary Sullivan could speak to data modernization efforts and the IT picture. The interoperability, I think, is what you're referencing with the federal government. There is a lot of work happening around that at the state level. Thank you very much, Vice Chair Collison, for bringing up this point. It was really wonderful for us in St. Mary's County to have you visit when we opened up our school-based health centers. And those school-based health centers are a prime example of what you asked about, which is partnerships, and how partnerships can be leveraged to improve health and wellness, but also to improve efficiency and access. So school-based health centers are a prime example of partnerships between health departments, nonprofit partners, other organizational healthcare delivery partners, and school systems. They are one example that many different health departments across the state are working on. And I know there's some support soon to be emerging from the Rural Health Transformation Program to improve the availability of school-based health centers in the state. You bring up an excellent point, which is partnerships can have an incredible synergistic effect on not just outcomes, but also in improving efficiency. I know in St. Mary's County, and I see Delegate Morgan came into the room. Good to see you, sir. We in St. Mary's County really, that's how we're functioning. I mean, public health functions that way around the board, but certainly at local levels where you kind of have to scrape together what resources and, guts you can to get things done and to meet the needs of your community members. It's so critical for us to have strong partnerships, for us to find ways to leverage resources, right? Make a network of resources, not just funding, but in-kind resources, things like facilities and people, and to be able to have those formal agreements in place that allow us to do that, and so that we can realize some of those efficiencies that you spoke to. I would say, as I had mentioned earlier, the infrastructure focus of the recommendations from the Commission is also about improving efficiency. When at the local health department level, our budgets, they vary from jurisdiction to jurisdiction, but when you have 60 to 80% of your budget driven by grants, and grants are often coming and going, and they have very narrow specifications as to how you can expend those dollars. It doesn't allow for long-term efficient planning. It doesn't allow for long-term investments well. And so that is when, block grants or general grants that don't have as many narrow specifications, as well as stable funding that the legislature establishes, as well as stable funding that the locals provide to their local health department, are so critical because they give us more flexibility to pull in our partners, leverage resources, really focus on what our local communities need, and get those solutions in place. And so I think funding is a complex topic, as you know, and it's not just about the dollar symbol, it's also about the restrictions that are on those fundings and how having less restrictions can actually promote efficiency and partnership. And also how investing in systems like data and technology and tools, right? I mean, AI is a tool that we're all talking about as a potential efficiency promoter, but certainly having a lot of those tools in communications and in data interoperability can also help promote efficiency. Some of the recommendations from the commission were about removing bureaucracy, essentially, in hiring. And I know Senator Lamb talked to this as well as he spoke about his bill. And if you can reduce the delays in the hiring system, then we won't be waiting 6 months to start spending the grant dollars. And then we won't have hundreds of thousands of dollars, sometimes millions, at the end of a budget year that we're sending back to the feds because we weren't able to expend it in time, right? And so if we can improve the efficiency of the hiring system, reduce some of the red tape that are suppressing local health department ability and also at the state health department then to hire, then we can realize the full benefit of those dollars and get those dollars working for Marylanders across the state.
Sorry. So first, I think, thank you, Dr. Brewster. I think you said pretty much everything, but I will just add just a couple of things. I think first, the question that you just asked, right, about funding, and I know we started our conversation talking about we are mindful of the funding challenges as we look at these, but absolutely our not just priority, but our responsibility is first to leverage federal dollars. And we tried to touch on that some, whether it is the Public Health Infrastructure Grant, that it does present a lot of opportunity around workforce and around data modernization and trying to make sure that we are not just looking at it from how many dollars are spent, but what impact does it have. We just the other day we're talking about how we have some extra funding and how we are going to work with local health departments around some broad framework of how it can be spent, but really give that flexibility though at the local level to make sure it is being leveraged and done so in a way that really works for on the ground. We talked about the Rural Health Transformation Program, which also offers a lot of opportunity right now, and including, we touched on a lot, whether it's school-based health centers, whether it's workforce, whether it's billing for local health departments. Again, when we talk about a time of funding challenges, we should be making sure that we're also maximizing revenue. So I think these are all some things that are incredibly key. And looking at when we know we have limited resources to make sure that those dollars are going to the places that are the most impactful, not doing things just because we've been doing them, but really making sure that we are doing it. We're also mindful it is a time of uncertainty with federal funding, and things can change, with one day, one email. And so really though, and even as we think about things like the Public Health Infrastructure Grant, like rural health, when future sustainability, we don't know what that funding will look like in a few years, much less now. And so I think as the same thing, we look at sustainability and how we really strengthen it using state dollars, using other ways, so that we're not, again, going from grant to grant or funding uncertainty.
Madam Chair.
Thank you. Delegate Kaufman, followed by Hutchinson.
Thank you, Madam Chair. Recent CDC data indicates that 1 in every 31 8-year-olds has autism. That's about 1 in every third grade classroom, to give you a sense of it. And when a prevalence of a disability is that high, in my view, it becomes a public health issue, particularly around education and things of that nature. So I'm just wondering, did the commission at all discuss autism and its rising prevalence? Thank you.
No, we did not. We did not really delve into the idea of specific risks or specific health effects on the population. In these 2+ years of work, we really delved into the issue of how do we provide the public's health, or a pathway to improve the public's health in generalities. Certainly the high prevalence of autism, as you've cited from CDC data, is of concern. It's of concern to a School of Public Health. It's of concern to public health practitioners, to healthcare providers. It needs to be tackled, but the commission did not specifically look at specific health effects in that population.
Madam Chair.
Yes. Thank you. Delegate Hutchinson, followed by Hill, followed by White Holland.
Thank you, Madam Chair. It's been a busy 3 weeks here in Annapolis, and I always get grounded when I come back here to this committee, because what we're really focused on here is improving health in Maryland. And we see a lot of different committees and commissions come in here with their tails between their legs because what they weren't doing and how they weren't doing it well. But I got to commend you. You're coming in here with a great basis to begin with. I think this is one of the most impressive reports that I've seen. I look forward to seeing the legislation that's coming. And I really want to give a shout out because the local health departments and what they're doing and their face to the community is just outstanding. I represent 4 counties, Caroline, Talbot, Dorchester, Wacomico. I visited all 4 of them. And so even with the restrictions, even with the challenges you've said, they're out there every day and putting a great face to my constituents on wanting to work. And I love that one slide, and it just said improved health outcomes. I mean, that's what we're here to do. So I look forward to working with the senator and this committee on the legislation and seeing us improve health outcomes in the long term. Isn't that so? Thank you, Madam Chair.
Thank you.
Delegate Hill for.
Either way. Thank you, Madam Chair. So I'm going to echo my friend and colleague from the Eastern Shore. My light went on and off because mostly I wanted to just congratulate you and thank you for the work and the completeness, and every question that I had as I looked more in the report, I found an answer to. I think, and you can tell me if this is correct, that part of the challenge you have is public health is something that is critical to all Marylanders, but most Marylanders have no idea that it exists or that it's important. And we saw during the pandemic how very important it was, but before we were halfway through, it became the most villainized part of our government, right? And so I think part of the challenge, as you outline it in here, and maybe the biggest piece, even more important than workforce shortage, which I think is huge, is public perception and having the public have a clear understanding of what public health is and what the jobs are that are being done and how it impacts their lives. And you've got a wonderful plan of how you're going to build that up, but you also have some pieces. And so the question I have is, you're already doing dashboards. Yeah. Do you have any information that you can share with us about who's using them, how often they're using them? And is the public beginning to see a greater role of using the dashboard and helping further or at least answer their questions and engage them in the thing we, so that's the question, dashboard use.
Thank you, Delegate. It's a really good question. And so for some of them, we have some of those metrics, sort of the click-throughs and what people are spending their time on, but it's actually something we want to figure out for across all of our key data elements. What are those key performance indicators that we would be tracking, and then to be able to share that more widely. We want to make it accessible and user-friendly, but then how are people actually using the data? We know when we start to do community-based work, just take the rural health piece, to be able to go and say, here's your county or here's your community's level data, this is how we want to fund. The firearm data, firearm dashboard is one great example. The grants that were made off of the 3 pillars of the Center for Firearm Prevention and Intervention were made based on where the prevalence data said we needed to focus on gun locks and safe storage. So we have that piece of really trying to integrate the information that we're getting from these dashboards into programmatic decisions, but then the consumer side, we have to build that out of what it means to engage with that data and how do we know it's helping. That's coming.
I might add to that many local health departments also maintain local level dashboards where we collect and gather data relevant to our local community, geography within our local community from many different partners in our community, including healthcare providers, including law enforcement, including human and social service providers. In St. Mary's County, for example, we maintain a dashboard that demonstrates data related to behavioral health that collects data from a variety of our partners locally involved in that work. We also have an air quality dashboard because we have a hyper-local air quality system in St. Mary's County where every public school has outdoor air quality sensors. And this was of great benefit to our residents when a lot of those smoke warnings were coming about from the fires in the north. and allowed us to really hone in our messaging and allowed our residents with asthma or other respiratory illnesses to really tune into what the air quality was in their neighborhoods and what measures they could take to be extra cautious.
So if I can follow up? So in that example, because you've been doing it for a while, are you seeing that the public is learning to engage more? Are they beginning, I mean, our greatest example, I think, was the COVID tracking out of the Hopkins dashboard. So you've had these in St. Mary's. Are people looking for them? Are they engaging more because of that?
Absolutely. We hear from our residents all the time. We also hear from our community partners that many of them are using these dashboards to articulate the need for the county in their grant applications. And so they're able to bring in more funding to their organizations, to the economy locally, to St. Mary's County residents, because they're able to leverage the data that we collect and put out there, along with the health information that we also provide related to that data.
Dr. Gazzoni asked, and do they know it's public health?
It's on the Health Department website.
Right,
We, as the commission recommended, we have several recommendations about how health departments can better engage with their members of the public to build trust, which I was describing as a force multiplier in public health for sure. And then also to make sure messages are reaching all members of the community in all different kinds of ways that are best for them.
And if I may just add to that, as Dr. Brewster mentioned, one of our themes was maximizing public engagement, which is part of what this dashboard is about. But our recommendation findings really emphasized public's interest in not just utilizing the dashboards, but also augmenting it with things like Facebook, Instagram. A lot of the people from the public seek this sources for their information. So that is one area that funding can be maximized, right? Again, to foster this engagement through diverse means. Thank you.
Thank you very much. And we have our final question on this briefing from Delegate White Holland.
Thank you, Madam Chair, and I will keep it brief here. And I appreciate Madam Vice Chair for elevating the funding question. I want to go back to that. But we've seen, again, for those in public health, we have seen historic cuts to public health funding for many years now. This is no surprise. And we still have struggled to get funding levels back to where they need to be with where we are right now. And we all know that what usually requires grants to function, that again makes it challenging regarding sustainability. And so can you expound upon these new funding models that you recommend in the report, beyond leveraging federal dollars more strategically and even examining efficiencies, which we previously discussed, but what do these funding models look like that can better position our state to ensure that we're getting back to where we should be, to ensure that the recommendations within the report paired with what we know public health will need to look like for the future, to ensure that the funding meets the moment and meets the expectation that our field is setting for us at this point in time. So can you expound upon that a little more?
Do you want me to go ahead?
Whoever is
I'll jump in.
Whoever is best equipped to
I'll
answer
jump
the
in,
question.
but I don't want to monopolize the mic here. There was a lot of conversation around this topic. It is very complex, and as I mentioned, for local health departments, and certainly Deputy Secretary Sullivan can speak to the state health department, but for local health departments, the majority of our funding, for many of us, the majority of our funding are grants. The state core funding is so critical for us because it gives us the flexibility that many of these grants do not give us to cover various, the full aspect, right? The full complement of programs and services, as is our local funding. And so those two sources of funding are really critical. I think there was a lot of talk across the commission how we shouldn't be so heavily reliant upon grants as a percentage of our budget, because then we're being swayed a little bit more by those grants, and we have gaps or holes evolve where we're not able to patch, right? We're not able to patch the holes that evolve in the community from a health and wellness perspective because we may not have funding specifically for those holes. So I think a couple of key pieces that came out of this, and some of them were already mentioned. I know Deputy Secretary Sullivan and the Assistant Secretary had mentioned the concept of billing, right? And looking at long-term, what is it that local health departments are doing? What is it perhaps that the state health department is doing that is capturable as a billed expense, right? And from health insurance companies or other entities that we might bill, we need to maximize our ability to bill where billing is feasible so that we can continue to provide services and programs where billing is not feasible to best address the needs of our community. So that's a key factor, which was talked about before. I mentioned block grants being much more effective and actually allows efficiency at the local level versus highly restrictive, specific, purposed, nuanced grants. And so as much as the state health department and others who provide grants to local health departments, as much as those grants can be made the least restrictive, even if they have the same core intent, it allows for local ingenuity. It allows for us to leverage resources locally that make sense. And it allows us to really lean in the direction that's best for our residents in each of our community. And then three, is the workforce development piece. And this is the building the future leaders of public health, building capacity at the local level to manage these complex budgets. Our budgets, about 100 different accounts often because of all these dozens and dozens of grants that we manage at local levels. And bigger health departments may even have more than that. And so when you don't have sufficient staffing to handle those administrative responsibilities in your fiscal office and accelerating the process of expending those funds through your HR office hiring processes, it really holds back our ability to effectively use what dollars that we do get. And also the workforce development piece of training staff up on an ongoing basis on these administrative fiscal management types of skill sets that we need at local and state levels.
And I think I will just add a couple of things. First, noting, though, that is obviously an incredibly important question of a very challenging one, right, as we think about funding models. And I think fair to say, when you talk about, a lower investment in public health over the last years, we need investment, right? And I think back to the questions around, we need to be able to tell those stories. What is public health? What is it doing? And why is it so important? And I think that has to be, is so obvious in the commission report and needs to be a continued focus. I think a couple of just other points that we haven't talked about. I think the first one that we really need to avoid is duplication of services, whether it is, right, the federal government doing something, state doing something, local doing something. And again, this goes around collaboration and making sure that when we are using dollars to pay for something, that it's not being done somewhere else in a different way and not having double the impact. And so we are really, particularly, I know at the state level, taking a really hard look at all of the services we are doing and making sure that we are minimizing duplication. And again, just echoing, it has to be in collaboration with the local health department so that we are really, really, really leveraging all of those. I think the second piece is, again, really around looking at every single dollar that is coming from public dollars, right, regardless of the source, is meeting a need that is needed in the community that is, again, not being met somewhere else or shouldn't be met somewhere else. So talk about revenue generating, but also our, the business roundtable, our stakeholder engagement, and really looking at where those dollars are going that are coming from our dollars versus others, again, to avoid duplication and make sure we're getting the most outcomes that we can.
No, thank you.
Well, I just want to say thank you all again for your expertise, for your commitment to this work, for continuing to move forward. And we look forward to being a partner in ensuring that that we have a tool that allows us to reassess and ensure our ability to advance these pillars. And thank you all very much for your time and for your expertise. We do have another briefing panel, our statewide maternal health landscape and maternal mortality and morbidity. I want to thank all of you who are here for that briefing, for your patience. We are going to take just a 2-minute break. We switch out the panels, and so everybody can get up and stretch for a moment. Good afternoon and welcome back to this joint briefing with the Appropriations Subcommittee on Health and Social Services for the House Health Committee. This is our 2 o'clock briefing on the statewide maternal health landscape and maternal mortality and morbidity. I ask for your patience if we encounter any technical or streaming issues. Now, this briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of their slides. Before this briefing, all members were emailed a copy of each presentation, and if you do not have these documents, please let committee staff know and we will send you a copy. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as meetings can run long and hydration is necessary. If a member is not present in the gallery, please understand that they may be attending other official meetings while remaining informed of the proceedings. And please adhere to our usual committee rules of 1 question and 1 answer from the panel, not 1 question and 1 answer from each panelist. Please make sure that your questions are brief and shorter than the answers. And this briefing is scheduled to conclude at 3 p.m. We are going to give some grace because we are already running a little bit late, and these are really important issues, and we're very appreciative. So we welcome back our Department of Health. Dr. Sullivan, our Deputy Secretary of Public Health Services, and our Acting Director of Maternal Health and Child Health Bureau, Public Health Services, Ileana Sarimalis. I don't think we've met yet, so welcome. If you want to go ahead and get started.
Yeah, wonderful. Thank you so much for having us here today. Again, my name is Meg Sullivan. I'm currently serving as the Deputy Secretary for Public Health Services, and joined here by my esteemed colleague, who we will hear from as well, and really appreciate the time to talk through today. We put together a few slides that really try and capture some of the current data that we are seeing related to maternal morbidity and mortality, as well as some of the work that the department is doing. I will say that the team gave me a lot of information to talk through. I'm going to not talk through it in full detail, just knowing the time, but definitely welcome questions on the data, and always happy to talk more. I think in just as kind of a brief summary, what we will talk about is just what a commitment and priority this is for the department. But if we look at the data and we delve into it, we know that while there's so much work that is being done, there's a lot more work to do, and we look forward to partnering with you. So next slide. So just, many of you may be familiar with the Women's Health Action Plan, which was published and developed and released in early 2024. And really just want to say at its core, Maryland, we know, values family health and is committed to protecting women's health, recognizing that when women are healthy and supported, families and community thrive. But even with these values rooted in our work, as I noted, we continue to see unacceptable disparities in maternal outcomes that are multifaceted and systemic, particularly for Black women and families facing structural barriers like limited access to care, economic instability, and geographic isolation. And our Maryland Maternal Child Health Bureau has taken a comprehensive approach to not only understand, but also to help eliminate this disparity, supported through our Women's Health Action Plan, which is grounded in reproductive justice, a life course perspective, and equity-focused data. Next slide. Well, we're going to talk a lot about data during when an individual is pregnant or in the postpartum period. I really just want to emphasize, we know that maternal health begins well before pregnancy and cannot underscore enough the importance of reproductive health planning and preconception health, and really supporting individuals to make those decisions to plan if, when, and under what circumstances they want to become pregnant, and ensure that they are in the maximum best health and have the supports they need to really set the stage for healthy pregnancies and outcomes beyond. Next slide. So again, we'll just talk about some of the data and the context for how our state is faring when it comes to health and well-being of mothers. And then later in the presentation, we'll talk about how we've responded. So first, just to talk a little bit about definitions, and again, don't want to get too into the weeds, but I think that when we look at the data, there sometimes are terms and definitions that help provide some of the context. In particular, some of the data that we look at differentiates between pregnancy-related and pregnancy-associated deaths. And you can see on this slide the definitions. So pregnancy-associated is really the death of a woman while pregnant or within 1 year of pregnancy conclusion, regardless of the cause of death. With the maternal mortality review team, which I'll talk about in a little bit, reviews each death that is pregnancy associated and then determines more in depth whether the case is pregnancy related, meaning the cause of death is related directly to a pregnancy complication or a chain of events initiated by pregnancy, or aggravation of an unrelated condition by the physiologic effects of pregnancy. This really helps develop recommendations for the prevention of maternal deaths. Again, underscoring every single death is looked at in detail, and then really determining how we can work to prevent them. Next slide. So the first data slide looks at the very initial postpartum period, so from pregnancy to 42 days postpartum. And what you can see is that in the 10-year period from 2011 to 2020, which is the latest data that we have publicly available, although we hope to release more updated data soon, the leading cause of early postpartum from 0 to 42 days was hemorrhage, all of which is considered to be pregnancy related, and most of which occurred among non-Hispanic Black individuals. Second leading cause included non-cardiovascular medical conditions, and approximately half of which are related to pregnancy. And then additional leading causes include pregnancy-induced hypertension or high blood pressure, which is seen more among non-Hispanic Black and Hispanic individuals, and substance use disorder, unintentional overdose, which is seen predominantly among non-Hispanic white individuals. Next slide. Then if we look at the next data, which I think that we can actually go to the next slide. Yeah, okay. Nope, sorry, next one. Let's skip. Yeah. Just to talk a little bit more about maternal mortality trends, for 8 consecutive years between 2013 and 2020, substance use disorder or unintentional drug overdose was the leading cause of pregnancy-associated deaths. We know that pre-existing behavioral health diagnoses, including depression, were observed as comorbidities in nearly half of all pregnancy-associated deaths and nearly 75% of deaths due to substance use disorder overdose in 2020. And I think this just underscores so much of the focus and the work that we need to do when it comes to maternal health and going forward. Next slide. This slide just looks at severe maternal morbidity definitions and trends. Again, just to kind of set the stage, Maryland's Maternal Child Health Bureau uses the CDC standardized definition based on hospital claims data. And what it has found is that hemorrhage, renal or kidney, and respiratory complications are the primary drivers of the increase in severe maternal morbidity in the recent years. We currently rank as a state 34 out of 47 of the 47 available data or states that we have for 2022 severe maternal morbidity rates, which again, I think underscores that we have a lot of work to do. We also the sustained increase that we've seen really mirrors national trends with unfortunately significant and persistent racial inequities, again, particularly for non-Hispanic Black women. And again, this slide really underscores some of those contributing factors that we have seen. Next slide. So this data really just highlights some of the trends looking both Maryland and national. And as you can see, Maryland's trends lines have mirrored national trends, with some potential reasons for this include increasing maternal age, higher prevalence of chronic conditions, and elevated C-sections, which we will talk about in a bit. Next slide. This slide just goes into a little bit more detail that really talks about the primary drivers of the increase in severe maternal morbidity during the delivery and hospitalization in recent years. I think what this slide also unfortunately highlights is that racism and discrimination continue to impact the health of Black non-Hispanic women. Some data that is incredibly important that we use called the Maryland Prenatal Risk Assessment Monitoring System, or PRANS, data from 2023 highlight persistent racial and ethnic disparities and experiences of discrimination among new mothers, which align with national evidence showing that racial discrimination adversely impacts pregnancy outcomes and really emphasizing the need to address both structural and interpersonal inequities in maternal health. I think just going back to the first slide too, the disparities emphasize the importance of preconception care to reducing prevalence of chronic conditions like hypertension, diabetes, and obesity, and the importance of improving management of conditions during pregnancy. Next slide. And then finally, for the last kind of data slide, you can see here is the percentage of low-risk cesarean births or C-sections delivered, the latest data we have from 2023. And I think what you can see here is that Maryland currently has 30.3%, which ranks 50th out of 50 among states and is above the national average. I think this is a slide, obviously, that is a data stat that is hard to look at, like so many of the others that we've seen. And the team is really trying to unpack what some of those contributing factors are, which we know are both at the healthcare facility and provider level, as well as some contributions related to risk factors during pregnancy, including advanced maternal age, obesity, or some of those underlying chronic conditions, and again, underscore a lot of the work that we focus on and we'll talk about. Next slide. So now just to spend a little bit of time talking about the infrastructure and programming at the Maryland Department of Health. we really have tried to mobilize both existing and new opportunities in programming to address underlying determinants and factors contributing to both maternal mortality and severe maternal morbidity rates. Next slide. And more than anything, our focus has been trying to have a coordinated, collective impact approach to really have the Maternal Child Health Bureau serve as the backbone infrastructure to provide leadership, guidance, and oversight to ensure quality improvement across programs. And through shared measurements and surveillance, we aim to track progress and identify areas where interventions are most needed, try and reinforce our service delivery strategies, and importantly, really look at sustainable investments and mechanisms to scale outcome or to scale efforts that we see are truly working. Next slide. So this graphic really tries to show the coordinated and collaborative approach that the Maternal Child Health Bureau takes. I won't go into all of these details, but I think just to emphasize the 4 key themes that we really try and look at. The first is around measurement and surveillance, making sure that we are looking at the data carefully and using that to inform what we do, to really, again, serve as the backbone for infrastructure and continuous quality improvement through efforts like the Maryland Perinatal Neonatal Quality Collaborative, the AIM Capacity Grant, and our perinatal system standards of care, to focus on sustainable investment and scaling and making sure that we are using and directing our resources that enable spread innovation and long-term systems change, and then mutually reinforcing programs and service delivery strategies. Again, all of the efforts that are happening both within the Maternal Child Health Bureau, across the entire Maryland Department of Health, and then with all of our stakeholders are collaborative in reinforcing each other. Next slide. So just to want to spend a few times talking about partnerships, which is so critical to the work that we do in supporting the implementation of recommendations to improve outcomes. We go to the next slide. We won't talk about all of these here, but just want to acknowledge the importance of all of our partnerships works. We'll specifically first call out our local health departments, who in all 24 jurisdictions truly serve as the front line for implementing maternal health programs, for collecting data and delivering community-based interventions, ensuring that state initiatives reach families where they live. We also know that regarding surveillance, MD Mom conducts active surveillance for severe maternal mortality and utilizes a different utilizes specific definitions that really allow for us to identify causes, medical history and risk factors, and preventability, as well as pilot innovative care models and interventions. Again, some of the other key partners you see on here, whether the Primary Care Coalition, whether the Maryland Patient Safety Center, really just emphasize how much the work has to be spread across the entire state and at all different levels. Next slide. Finally, just want to spend a little bit of time talking about strategies to decrease severe maternal morbidity and maternal mortality. And again, we are really looking at some of the themes that I talked through. What is already in place that we know is working? What is in progress that we are looking at and watching the data to determine how we can best scale that up? And then always looking for innovative ways to explore additional efforts that we can do, because again, we know the data is not where it needs to be. So for example, on this slide, looking at, we already are expanding diverse community-based perinatal workforce infrastructure, just with some examples here that you see on these slides of some of the work that's being done at the local level. We are working to further streamline care coordination and referral pathways, including by supporting hospitals and implementing community responsive clinical policies and practices, and then looking to further standardize and implement safe, supportive postpartum discharge practices across all birthing hospitals. I think this standardization and uniformity is something that we've been working toward and want to continue to focus on. Next slide. And then just to talk about scaling impact and improvements. So using the same metric, these next couple of slides just emphasize a few of the examples, in what we already see in place, findings from the University of Maryland Capital Region Postpartum Hypertension Collaborative and the Howard County Peace Project Doula Partnership Program, really seeing some really important work and results being done. We know Be More for Healthy Babies at the Baltimore City Health Department really is a place for central intake and comprehensive support and helps inform initiatives across the state. And then working with Frederick County Universal Family Connects, Frederick County to implement a program around Universal Family Connects, or Chesapeake Healthcare Federally Qualified Health Center looking to implement some innovative programs as well. Next slide. And that was a real snapshot, high-level snapshot. There is really an incredible amount of work being done, and we're really happy to answer questions about it. But just want to thank you for giving us the opportunity to talk about it briefly, and I really look forward to partnering with continuing the work with you. So thank you.
Thank you, Madam Chair. Everything I read about maternal health care suggests that a major problem is unconscious bias among physicians, where they don't take women's complaints, concerns of pain as seriously as men, and that's for all women, but particularly women of color. And so as part of their education or as part of a CEU, continuing education, are OBGYNs in the state in any way required to take a training on unconscious bias?
I don't want to speak, I'm not sure if it's required. I think that there was some legislation that may have been proposed around implicit bias training. But I do know in some of our quality improvement collaboratives, we do focus on implicit bias. And then also we launched a statewide version of the CDC's Hear Her campaign, which grew out of just being able to listen to women and understanding that women are the experts in their own bodies. And if they're explaining or if they are expressing concerns about complications during and postpartum, just so that providers are taking their feelings and their concerns seriously. So I think that those are some efforts that have been done. I would like to get back to you about the question regarding if there's a requirement for provider training around implicit bias. But I do know that some of our QI collaborators have reinforced that piece as part of broader quality improvement efforts.
And I just couldn't hear one thing that she said. Can I ask her one thing, because I just couldn't hear it?
And if I may, Delegate, I just wanted to say that yes, it is required through the health occupations for implicit bias training. We also had a bill on structural racism, and that particular program is still in development.
All right, well, thank you for educating the new kid on the block. That's really great.
Absolutely. Great question. Go
I
ahead.
couldn't hear what I couldn't hear what you said. What is that program called where you say you hear her or she hears or something?
It's the CDC's campaign called Hear Her. It was released a few years ago, and Maryland invested in its own statewide version campaign that ended around a few months ago, and we are currently evaluating the impact of that public health awareness campaign.
Thank you. Thank you for your indulgence.
Of course. Madam Vice Chair, followed by Delegate Alston.
Thank you, Madam Chair. Thank you for this work. So from my perspective, the good news is we now have data that tells us why, which we didn't have when I started here 16 years ago, and we were talking about this. The bad news is we haven't improved. And so I'm a little disheartened by the fact that we still have these really high levels, and particularly racial inequities and disparities in the outcomes. So I'm wondering, we've spent a number of years talking about the role of the community health workers and doulas, and I see that Howard County has done something. I mean, can we ramp that up? Can we scale that up? Can we make that an active part? Can we team doulas, a team of doulas with an OBGYN who are following up on people? I mean, are those kinds of programs being considered?
Yeah, and I think first, and I'm going to have Ileana speak to the programmatic level, but I think first we'll just say, I mean, these are the questions, right, that are eating at us. I mean, we've spent even just hours this week talking about it, right? I cannot underscore enough, I've been in this role now for almost 6 months, the work that the department, that our stakeholders, that's local health, I mean, so many are doing is really just so much, and there's so much to talk about, but the data just isn't there, and it is really hard to see. I was up late last night, reading about some of this data and trying to think what is it. So, I think to your point, it is challenging, and it underscores us needing to look for innovative work, including doulas, which I know has been a priority and even something that we're even looking to scale up further. But I don't know if you want to talk about it more.
Yeah. So to the doula piece, we actually have been investing some small grants in a couple local health departments to support their doula workforce capacity building. And that's currently being evaluated by a third party to see what are the impacts of that investment, that grant. Was it able to get more doulas credentialed, enrolled in Medicaid, provide and seek and see more women during and after their pregnancy? So we're currently evaluating that. That's something that we have recently invested in. In addition, when you're talking about kind of the diversification of the perinatal workforce, that is a priority for us. We mentioned it briefly on the slide, but we are working closely with our Postpartum Support International to actually do some mental health, to train a variety of providers around mental health awareness and service delivery to support pregnant and parenting women, because that's something that we found is related to, unfortunately, higher rates of maternal mortality and substance use and overdose. So we're trying to ensure that we are looking at the mental health needs of women before, during, and after pregnancy. So that's something that we are investing in, because we're not just talking about providers, we're talking about a range of healthcare professionals that see or intersect with pregnant and parenting women to ensure that their mental health needs are being addressed. So that is something that we started to implement a few months ago, actually, and our goal is to train 75 providers, professionals annually with that program, and to get certification in perinatal mental health.
Great, thank you. I think that's helpful.
Thank you. Delegate Alston.
Thank you, Madam Chair. I know that our subcommittee chair on maternal health will be rejoining us soon with lots of questions. But until then, my first question is, how many Black doctors did you all consult with before you all did this briefing?
Sorry, before we did the briefing?
The briefing materials that we just received, how many Black doctors were a part of the research that you all just provided to us?
I'd have to get back to you on the representation, but we have different providers representing our committees, our coalitions, our Maternal Mortality Review Committee also, so I can get back to you on that information.
Yeah, we definitely like to see that number. I will tell you that I do have a concern that with the numbers that we heard about the number of women of color, specifically Black women, dying in childbirth, it is a very dangerous job for women that look like me to give birth to a baby. To not have anyone that reflects that diversity on the panel or hear from that population is concerning, coming from the health department. So that's the first concern I have. The second thing is, a lot of the data, this is not necessarily new information. These pre-existing comorbidities are a part of the culture, and not knowing or understanding how to treat for that when people are pregnant is a problem. And so I'm just not clear on how you all are being culturally responsive to the very specific problems of Black women going through pregnancy. Because high blood pressure, diabetes, high cholesterol, these are problems that are systemic in our culture and in our neighborhoods because of lack of adequate food, lack of good health care. And it's not that it's not known, so giving us a report that kind of tells us what we know without more is disappointing. I know you all have worked hard on it, but I would really like to see the work from others, and I'm glad that our subcommittee chair has joined us so I can, it's been a while since I gave birth, and the day I gave birth, there was a woman in the hospital, also Black, who died, and this was 23 years ago. So this isn't new information. these have been problems for a very long time. And so I would like to see a culturally responsive and culturally sensitive approach to how we tackle this problem in this state.
Delegate White Holland.
Thank you, Madam Chair, and pardon me rushing back in. I was fulfilling my obligation and pumping for my baby that I just had 6 months ago. So I appreciate, again, you all being here, and I also appreciate my colleagues raising their questions. Of course, I have a slew of questions, but I'm going to ask my one good question, Madam Chair. And I appreciate you all elevating.
As chair of the subcommittee,
Okay.
well, I will give you some leeway.
All right, fair enough, thank you. So I know that you all elevated a number of the programs that we have, and we'll hear also about MD Mom as well. But again, and I think I echo the sentiment of my colleagues here, that it is really concerning for us to see these stark inequities, these racial disparities that we see. And as someone who sees themselves in the data and who is living this in real time, not just from my own professional background, but now in my own lived experience in dealing with some of these other things as well medically, I really want to understand, what is this disconnect, and what is it that is going to require us to really look at the root causes? You elevated systemic racism, you've acknowledged it, but how are these programs, these initiatives that are speaking to that, how is it addressing that beyond the implicit bias training that we know that this committee works on? But how is it speaking to these larger systemic issues that we acknowledge are a problem, and yet we still are not seeing the type of improvements that we need to see? It is really unacceptable, and we've all acknowledged that it's unacceptable, but really, what are we doing about it? And given the tone and tenor of the question that was asked previously, how is it that we are ensuring that those who are closest to the problem are also a part of the solution? They're already doing the work in the field. The work is happening in the ground, but how are we also as a state ensuring that there's the appropriate resource and partnership that's happening, that's amplifying some of the work that even Madam Vice Chair elevated, that we know is working in communities? So a multitude of different questions baked in one, but just wanted to speak to the systemic issues. How are these programs addressing that? And two, how are we really making sure that we are elevating the work that is happening in community by Black women?
Yeah, and I think what the first thing that I will say is, these are the questions and conversations that we absolutely need to be having and are having. And, I think this was an opportunity for us to come in here and talk about some good work that is happening. But and I think you missed me saying this, what we have been talking about leading up to this briefing is not about the good work, but about what the data does not reflect that work. And so what more do we need to be doing? And I think I can not emphasize enough the urgency and the intent, or the frustration that we feel, the challenge, or the recognition that we need to be doing more. I will say, I think, in one of the reasons we wanted to start the presentation talking about preconception health, right? That we recognize that so much of this is systemic. This is not just about if and when a woman becomes pregnant, but underlying chronic disease, underlying social determinants of health, and then to your point, we talked about disparities, structural racism. I'm a practicing pediatrician. I have had the opportunity to do training in implicit bias, in having these conversations, but it's certainly not enough. And again, we're not seeing where those outcomes are. So I don't have all of those answers today. I don't think we do. I can assure you we are asking ourselves these questions and challenging them. Can also say, and I think we did try and highlight this to some degree, you talked about incorporating people with lived experiences, incorporating other partners. That is something that we are striving to do. We can probably do better, and I welcome all of the feedback that you have. I know Ileana can talk to it more, but recognize, right, this is not about doing work just, in a bureau in the health department, but really making this a community-wide effort, and we still have a lot more work to do. Ileana, do you want to add more?
I'll add something. Internally in the department, in the Maternal and Child Health Bureau, when I came on board, I noticed that a lot of our programming was done in isolation. We had this QI project over here, we had this surveillance program over here. And what we started to do with my predecessor is really think about what does the perinatal health continuum look like? How are we working together? How are our staff talking to each other? How are we looking at the data? How are we looking at these findings? How are we elevating local innovation? So that way we can look at, okay, what can be spread and scaled statewide? How can we braid funding? How can we be really creative with those partnerships? So that's something we started to do, I want to say a couple years ago when I first came on board, because we noticed that this work can't be done in isolation. The accountability is not in isolation either. So we're looking at what are we doing to support provider capacity and help them understand what they, how are they administering services? How is care coordination handled at the local level? What happens upon discharge? How are we following up with these women? Are these approaches effective? And also looking at what are our sister states doing? What's working for them that we might want to look and see how we can adopt to our state? So in the Maternal and Child Health Bureau, a lot of our programs span over 3 offices. And so trying to be very coordinated about what is our perinatal health strategy? What are we looking at? What's the data telling us? Why are we working with the same partners at the local health department? How are we making sure that we have streamlined messaging, training, measures, and also just being able to look at data and not just dashboard data, but also looking at what are the programs telling us in their quarterly reports? What are we finding from our local health department staff? What are we looking at? What are providers mentioning? What are the mothers telling us also? I think is also important. We are trying to think about incorporating lived experience across all of our population domains, including mothers, including youth as well, because we're finding that they're the experts in their own lives and their experiences, and we need to know what are we doing that's working and what are we doing that's failing, and how do we stop investing in those failed approaches. And then again, we really wanted to highlight those local innovations because we see things working, but if they're only working in pockets of the state, we're not reaching a vast majority of women. So just wanted to acknowledge that we are doing some very concerted efforts internally to ensure that our workforce is accountable and is responding to these needs for our constituents.
No, I'll yield to it.
Delegate Alston, did you have a follow-up question?
I did. It's actually a different question, so I don't even want to pretend it's a follow-up, but may I please ask it?
I will give you some latitude.
Thank you very much, Madam Chair. Jeffrey Cooper is a constituent and, full disclosure, a family member, and he has been working on an app that would monitor the rates of diabetes, high cholesterol that would feed right back to the doctor. And I know he's consistently come to the health department asking that the health department set up a pilot program where AI and technology can be used to facilitate making sure doctors know what's going on with their patients in real time before we get to the birthing room and before we get postpartum. Have you all looked at that at all?
I'm not aware of that, but I would like to follow up on that if possible.
Appreciate it. Thank you.
All right. I'm looking for any other lights before I make comment. This is tough. I think you hear from our committee that we are concerned because there is a sense of urgency in this committee. We've done a lot of work. I've heard a lot about the conversations that you've been having over the last 2 years. I didn't hear speaking to looking at the legislation and what the legislation calls upon us to do. We know that we've got data dashboards now, so we can track the data. We know that there was a concerted effort to create data dashboards that actually compared like to like, because we were very behind in that. We know that the department has been working to map this problem. And last session, we heard a lot about some of the programs that are working really well in pockets across the state. They were targeted funding, leveraging federal dollars with state dollars, and we were seeing improvements. And they were targeted programs with measurable improvements across the state. But I think the worry is, again, we only have 90 days. I think we have 70 days at this point. And at what point do we stop mapping the problem and make sure that we're advancing those outcomes so that we're not here next year having the same conversation? So I think you've heard a lot from our committee members. Our subcommittee chair, I know, is happy to avail herself of you. But I'm going to make an ask, and that's that before the end of this session, that you come back and have a conversation with us. And you can do it through our subcommittee chair. She's incredibly skilled, and I know can convey that message. But if we could understand what the commitment is to make sure that we're not backsliding, because this is also a very tough landscape in health. We don't quite understand what our federal funding is going to look like. We're still in the process of advancing the HEAD model, and so I think it's very important that we reassess those conversations and make sure that before this session is over, we've got actionable policies, whether they have to come through the legislature or whether they just have to come through the department. But I think there is a real sense of unease. And so I'm going to make that ask that we partner together, and before the end of these remaining 70 days, that you're willing to come back and we can talk about how we can make these actionable.
Yeah, absolutely.
Thank you all very much for your time and your expertise. I know we have another panel, so if I can ask MD Mom.
Already here.
Oh, you're already there. I wasn't sure, but if you can go ahead and get started. Is it Dr. Krania? Okay, I'm trying not to butcher names today. Whenever you're ready, go ahead and get started.
Okay, thank you. Thank you so much. Good afternoon, everyone. Thank you so much for having me here. My name is Andrea Krianga. I'm a professor and chair of the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. I'm a new chair. So again, my name is Andrea Krianga. I'm a professor and chair of the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. And it is my pleasure to be here with you today, invited to talk about the Maryland Maternal Health Innovation Program. I'm not going to go over all the slides because there are too many, and I don't want to repeat some of the good information that my colleagues from the Department of Health have already presented. So I'm going to just say that we are one of the 42 states in the country funded by HRSA to have a statewide program trying to improve outcomes for mothers and families in the state of Maryland. And with that, we have started back in 2019 with the first round of funding from HRSA. The first 4 years, we focused on key elements of the program that I'm going to go over. And then with additional funding from the same federal agency in 2023, we are able to continue the work that we started until 2028, September. Part of this work is actually done in collaboration and close coordination with the Department of Health and also with the Maryland Patient Safety Center. Very grateful for their collaboration over the past 6 years and a half. With this program particularly, we are able to establish a statewide task force for maternal health. For the first time, the state has a task force that is dedicated to maternal health and not maternal and child or maternal and infant health, which we know we used to have in the past. So very targeted efforts to address the needs in the state and exactly addressing the issues that you brought up over the past, I think, half an hour. So with this work, we have two strategic plans that have been developed for the state. First in 2021, it was right after the pandemic, and another one in 2025, September. This is, I think, a very good strategic plan for the state, again, collaboration with the Department of Health and many, many stakeholders that are part of the task force. The task force actually has two co-chairs. One is a clinician, one is a community health worker, and I think in the room with us today, she's the next presenter here. So I think overall, the task force has been really important in bringing people together. We have clinicians, we have community-based organizations, we have health agencies across the state, represented professional organizations as well, coming together and trying to do the best possible for women and families in the state. So moving from there into more about our program. This is a very busy slide, but I want to show you that we have many, many partners at the national level, of course, but also at the state level. We are working very closely again with the Department of Health and trying to integrate all the data that has been shared with you, and they have, but also we are trying to complement the data that they have. So with our key activities that are in blue, dark blue here, number one, this was the very first piece that we initiated back in 2020 with this program. We wanted to learn more about severe maternal morbidity. So the trends that you have looked at are based on data that are codes in administrative data. So of course, those are prone to coding errors, and they do not actually give the clinical nuances and the clinical information that is needed to understand severe maternal morbidity and the root causes for such. So with this particular program, we are the first in the country to have such a program statewide. It was with your support back in 2024 with the passing of the Maternal Health Act of 2024 that this program has been mandated. All the hospitals participate in the surveillance system, and this is facility-based surveillance for severe maternal morbidity using a specific case definition that is ICU admission and or receipt of 4 or more units of blood products. With that particular definition, we are able to look, examine, and review the most severe cases of morbidity in the state of Maryland, across the state. This is important because we want to make sure that we understand the root causes and we go beyond what administrative data can tell us. So we are looking not only at clinical data, but we are looking at social factors that are captured in EHR data, both structured and unstructured data, but also looking at, we are doing interviews with patients who have experienced severe maternal morbidity in the state. And those are important. That's important information that we can actually add to our surveillance system by way of adding a specific module looking at social factors in our surveillance system. We were the program that actually offered the implicit bias training to providers 3 years ago, and into 2023, we were able to train 4,000 perinatal health providers in the state of Maryland across all the hospitals with a specific training developed by March of Dimes. There have been efforts to follow up on that training with additional skill building exercises for providers that we were able to develop in-house with our program, and we are able to deliver to hospitals, working with the same 32 birthing hospitals in the state of Maryland. I'm going to skip to the telehealth initiative. I want to keep this as brief as possible so that I'm able to answer your questions. With the telehealth initiative, we are addressing some of the issues that were raised here over the past 30 minutes. So this is a telehealth initiative addressing hypertensive disorders of pregnancy. We are distributing free blood pressure cuffs to patients who have high blood pressure during pregnancy and postpartum. We do this work in collaboration with 29 of the 32 birthing hospitals in the state. And to date, we are able to distribute more than 12,000 blood pressure cuffs across the state of Maryland. This was done again in collaboration with the Department of Health and the Perinatal Quality Collaborative, given that the state has been implementing the safety bundle for addressing severe hypertension in pregnancy. So we are trying to complement their efforts and bring everyone together to address the same problem at the same time. And then with our task force again, and I'm sure my colleague, the next speaker, is going to talk about this, but from the task force, we understood that one of the key gaps in the state of Maryland is in maternal health is the fact that women did not know that services are available to them and where they can find these services. The same goes for some of the providers, right? Especially providers in hospitals, physicians, OBGYNs, not knowing what type of community-based services exist or type of social services exist in the state of Maryland. So what we did, it was a task force initiative that we were able to carry out and develop a map, a resource map for maternal health. That map was through that map, we were able to identify and map more than 2,500 resources, services that exist in the state of Maryland that women can access. And this is work that is continuing. We have, 2 years of experience with this map. We have reached more than 240,000 women. And I think about 150,000 individual users for the map. We have done quite a bit of work advertising this resource, making sure that we reach, various women and patients and the general public in various different ways, using different tactics, including social media, but also, we did transportation ads and we were in newspapers and we did everything possible to make sure that we increase awareness around this map and the use of the map at the state level. So I'm going to stop here. I know I'm probably over time, so I welcome any questions that you may have for us for the program.
I'll start with Delegate Alston.
Thank you, Madam Chair. I'm just wondering, I know a while back, some organizations were having trouble getting the data they needed from hospitals and the Department of Health, and I'm just wondering, has your organization received any problems or impediments to getting the information, the surveillance information you need in terms of records of women that have passed away or have had complications during birth? Have you had any trouble, and if so, has it been resolved?
Yes, and that is because of your help and the fact that we have the Maternal Health Act of 2024, and one of the 4 provisions in that legislation is a mandate for hospitals to contribute to the surveillance system, again, to get that clinical information that we need.
So you're no longer having problems accessing the information?
No, we have a system in place. We have IRB approvals. We have data use agreements. Everything has been put in place, and we are rolling, very, very well.
Thank you. Thank you.
Madam Vice Chair.
Thank you, Madam Chair. And thank you for being here today.
Sure.
So I'm not clear whether you actually have some programs that you are delivering. And if you do, I mean, I heard you talk about the distribution of blood pressure cuffs. I guess I'm interested if you have something that is showing great promise and that you're actually seeing improved outcomes with the women that you're working with.
I think we do. With the severe maternal morbidity surveillance, we are seeing hospitals implement key clinical and also policy changes at the hospital level. So we collect this information from them, just like we collect the information on the patients that experience severe maternal morbidity. And we, I think on one of my slides, I actually have a listing of improvements that have been made over the past, I would say, 6 years on data, also education for the workforce, and also quality improvements. So specific actions that have been taken to address the root causes and the key, I would say, factors that lead to severe morbidity in hospitals. That's just an example. I can go on if you want, but definitely the telehealth initiative has been successful, having women, empowered to actually have the blood pressure, the blood pressure readings and measures, and able to act on those measures and reach out to their providers so that they are followed up with.
Okay, thank you.
Delegate White Holland.
Thank you, Madam Chair. And Dr. Krianga, good to see you again. I wanted to couple some things together stemming from the conversation we had earlier related to funding and the report of the Commission on Public Health. I see these things intertwined because this particular task force and the work that you've been doing with MD Mom, again, it is grants driven.
Yes.
Where we can see the the work that you all have done, essentially because of the fact that it is grant funded, it is possible to see that some of the initiatives and work that you've done could potentially conclude. Have there been any conversations, given the work that you're doing within the hospitals, as an example, and thinking about how we can better improve our internal systems and processes at that particular institutional level? Have there been any conversations about how we can better institutionalize these initiatives if they are working and we're seeing that there's some great benefit to it? Have there been any conversations that the task force has had with our state partners to see how they can be fully integrated within our existing public health cadre of programs and initiatives? And what are the other ways, and again, because thinking about grants, what is supported via grants isn't always sustainable.
Yes.
So how are we going to sustain the work that we've done in this particular task force, and what have those conversations been?
Yeah, that's a great question. So I think the strategic plan that was developed in 2025, and again, the next speaker is much better able to talk about it because she was one of the co-chairs of the task force and deeply involved with this report. But I do think it's a really good product for the state. So I really think that the 4 goals that were put forward do address the need for funding and sustainability mechanisms to be able to continue this work, not only the work that we are doing, but also the work that has been done across the state with the various programs. And I think the Department of Health has been integral to these conversations and also to putting together this plan. So I really, they deserve a lot of praise for the work that has been done on this particular plan. So in the plan, you are going to find not only the goals, but also ways in which every single program in the state of Maryland working in maternal health is able to work towards meeting those goals. In terms of funding per se, with MD Mom, we are looking, we are federally funded. So last year, of course, we weren't sure if we are going to be funded until 2028, which was our expectation. So we started to look for additional funding, and we are looking at philanthropy, private donors, trying to ensure that we have, a way to continue the work that we are doing. And in addition to that, to maybe grow the work that we are doing. But I think it is a task force that is going to, even in the future, in the next couple of years, we are trying to reorganize the task force a little bit to increase membership as well, so that more people are going to be part of it and be able to contribute to this.
Mm-hmm. Thank you very much. Thank you for your time and your expertise. I know we have one more panelist on this briefing. So if I could ask Tanya Lynn Harris, the director of the Bloom Collective, to come to the table. Thank you. Just for the sake of planning, for those who are here for the bill hearings, we'll be starting the bill hearings about 10 minutes after the conclusion of this briefing.
Good afternoon. Thank you to Madam Chairs for the opportunity to come and present. Although the document does say Tanae Lynn Harris, the Bloom Collective, I'm also representing primarily as the Maryland Black Perinatal Health and Reproductive Justice Policy Collective. For the past 3 years, a committee has formed and hosted the Maryland Black Perinatal Health and Reproductive Justice Summit. This convening has gathered perinatal health leaders, including doulas, clinicians, midwives, researchers, OBGYNs, nurses, advocates, academics, and scholars, and others to discuss the past, present, and future of the Maryland perinatal health and reproductive care landscape. From this convening, we have formed the Maryland Black Perinatal Health and Reproductive Justice Policy Collective. And on behalf of the collective, we wanted to present a summary of some of our legislative priorities and things we really want to be focusing on. I do want to acknowledge that when we do have this summit, usually there is somewhere between 150 to 175 attendees. And then the folks who are coming together from the policy collective are somewhere between 60 to 80 people who are giving up their time, talent, and treasure who are not funded by any particular entity. They are doing this work because they're extremely passionate and they know that this is directly impacting them, the people that they love in the community, and all of Marylanders. So we do hope within the next few weeks that we'll be able to finalize our comprehensive perinatal and reproductive health policy agenda for Maryland. And we believe this document will be a vital first step towards securing our abundant, strategic, and joyful vision for Black people across our state that, in essence, will benefit every single Marylander and beyond. And as a collective of perinatal care workers and service providers, reproductive justice advocates, policy experts, we strongly encourage our elected officials to deepen their allyship by continuing to fight for reproductive health rights and justice. And so first, we want to acknowledge that as we came together, we thought it was extremely imperative to center birth equity and reproductive justice in any efforts to address Black maternal mortality and morbidity. These are not just words that oftentimes are used. There are particular frameworks and a guide that allow us to do the intentional work that we need to be doing. And so reproductive justice is defined as the human right to maintain personal bodily autonomy, have children, not have children, and parent children in safe and sustainable communities. And this encourages us to ensure that people have all that they need to make the best decisions for their lives, and that honoring a full constellation of care will help ensure and providing the utmost respect to our community's patients and clients. And so the top things that we had mentioned on the document that you'll see, that we really believe that if we would center perinatal leave, the issue being that as of right now, perinatal leave will not start until 2028. We need to really increase paid parental leave policies to at least 1 year instead of just 12 weeks. That we need to provide at least 6 months for non-life birth for parental leave. So that would be someone who has lost or had a stillborn child. As we're thinking about maternal mental health, the issue being there needs to be an increase in providers in Maryland who specialize in perinatal mental health, also known as perinatal mood and anxiety disorders or even maternal health. There is a critical workforce shortage, and we need anyone coming in contact with the birthing community who needs to be trained in perinatal health to better understand perinatal mood and anxiety disorders. Solutions could look like legislation to provide funding for birth workers to be trained in perinatal maternal health, PMH. I think when you see birth workers, I really want to put this on record for you all to understand. You will not find many Black folks who like the term doula, for a very specific reason, thinking about how we decolonize and reframe our verbiage to also include birth worker. We could also, another solution would be requiring licensing bodies to consider including perinatal mental health trainings for behavioral health and medical providers. Also legislation to require screenings and create funding sources to encourage screening during perinatal and postpartum period for all providers serving birthing people. Additionally, legislation providing funding for underinsured or uninsured individuals to access perinatal mental health services. I want to add a storing in here. You would look at someone like Kristen Brooks, who runs Building Beyond Therapy in Upper Marlboro. That is a private practice. And so oftentimes she is having to find ways to raise money to continue to provide perinatal mental health services to her clients, right? So there is uninsured and underinsured, and there are still people who are not 501c3s, but they are everyday private practice and clinicians who are doing the work in their everyday communities to provide this important work. Severe maternal morbidity, we do really have to look at mortality and honor what is happening there. We also really, as some of our previous colleagues and speakers have spoken, really looking at morbidity. Nearly 2/3 of severe maternal morbidity events in Maryland are considered preventable. With changes in clinician level factors and interventions in the antepartum period, having the largest potential to alter the severe maternal morbidity outcome. And what we do know from all of the data is that Black and brown birthing people have higher percentages of non-emergency cesarean sections. Solutions would be reduce clinicians' unnecessary interventions, such as non-emergency cesareans. Its support with amplifying the importance of continuity of care, birth workers, doulas, midwives, nurses, OBs, lactation practitioners, perinatal mental health providers, and so much more who make up the constellation of care, all can support with holistic touch points to make transformative change in birthing experience and outcomes. And what we do know is that if a birthing person has at least 2 to 3 touch points with various providers, we do see a high level of outcomes totally transformative and change. We do really need to consider in the state of Maryland freestanding birth centers. The issue being freestanding birth centers in Maryland have struggled with the requirement for collaborative agreements with physicians, high liability insurance costs, and low volume. Maryland residents have fewer options for birth, which actually decreases autonomy in our birthing choices. We are making the choices for people. Solution would be remove the requirement for collaborative agreements with physicians and reassess other requirements to make birth center operations more feasible. Breastfeeding, chest feeding, lactation reimbursement, issue being some older grandfathered insurance plans are not required to follow the ACA mandate for free in-network coverage for IBCLCs, which are internationally board certified lactation consultants. They are the highest that you can be. Over the past few years, just to put into context, lactation as a profession, you're looking somewhere closer to the 1990s. Usually it was just the nurse or the midwife that was, talking to you about lactation, but now there's a study around breastfeeding medicine and why that is important. And so IBCLCs are also a part of that arc. And so what this is looking like is that it's not just nurses. You can be a community practitioner who can get 100 hours in clinical training, didactic, and then you also can do somewhere between 500 to 1,000 clinical hours as well that then will get you the credentialing of an IBCLC. Solution could be clarifying that all health insurers must cover IBCLC breastfeeding services, and that Medicaid reimbursement for IBCLC and lactation specialists and the creation of billing codes to include lactation consultants under Medicaid reimbursement. We could also uplift the various lactation, breastfeeding, chest feeding credentialing, such as a certified breastfeeding specialist and the certified lactation consultant, who also offer opportunities to provide lactation and infant feeding support, which help with breastfeeding initiation, duration, and succession. We also want to heavily acknowledge the criminalization of pregnancy and parents. Along with Movement for Family Power, we have wrote a document that drug test is not a parenting test, and something for us to really be considering around the sometimes unintended harm that we put onto Black and brown families. So issue being that Black women are more likely to get involuntarily drug tested. Solution being that we require consent for drug testing and implement accountability for those who do test without consent, and that we also remove mandated reporting requirements in Maryland and reconsider what that looks like. I don't want to take up a lot of time, so I'll leave it for you all for any particular questions that I can answer within my purview. Thank you.
And I'm going to start with Delegate White Holland, followed by Delegate Tavares.
Thank you, Madam Chair, and thank you, Ms. Harris, for your presentation and providing us with tangible policy solutions that we can put forth. I would like to elevate, and if you could share a little bit more and maybe provide some examples around the community-based interventions that are working that can be better amplified and lifted up. I know Madam Vice Chair previously elevated our community health workers and those that are being deployed in our communities and how we can better scale up those particular type of interventions. So can you expound upon what does that look like and what, from your vantage point, with the work in which that you do in the community, speaking to the larger continuity of care, can you provide us with some examples around what that looks like and what's working?
Yeah, I can share from our vantage point from the Bloom Collective. We are a collective of various practitioners who do this work. When we first started, we had midwives. We also had perinatal mental health therapists. We had birth and perinatal doulas. We had folks who provided consultation around folks' reproductive health choices. In addition, we had lactation. And so one of the things I want to mention is that we did not have funding. It was our community that was giving us $5, $10, $15, $20, and we were fundraising within our own communities. There's oftentimes not the same amount of funding that comes to those of us who are in our own communities doing this particular work. A lot of the money that is oftentimes implemented, though you hear the term community-based, is oftentimes saved for those who can receive federally funded allocated dollars. And so there's a shift into that dynamic, right? That is just really important in mentioning. And so although we did not have a lot of funding, what we built was a free to sliding scale payment option. So there was no questions that we asked you for you to prove that you needed anything for free at a discount. And then we also had clients who would pay if they could. So if someone could afford a doula for $1,500 or $2,000, depending on that large scope, then they would do that, right? And so this really looks also being in concert. So building and cultivating relationships with pelvic floor therapists, building and cultivating relationships with chiropractors. And so this becomes extremely important that we can let our clients know we are seeing this within your body and that we heavily recommend this. And these are 3 to 5 practitioners in our own community that we trust. And then here goes an additional list of people that you can find out and learn from your own, within community. And so it's really just looking at the entire arc, being together through the ecosystem, knowing that we're not alone. And so the more that we can do this work in concert with each other, not create these unnecessary hierarchies that are oftentimes implemented to be very paternalistic to the type of work that we're attempting to do in our own communities, it's actually causing harm. Where we're really trying to do is make some type of transformative change in our communities, because as we are seeing, this is a time and time again conversation. People are constantly dying, but they're not only dying, they're being harmed. And so we have to think about the long consequences that happen when you've been harmed in the hospital setting. That takes a good amount of time to heal from. And you might not ever heal from it, but we have to be in concert and continue to work together.
Delegate Taveras, followed by Hill.
Thank you, Madam Chair. And I'll be quick. So the two questions that, well, one question that rises up is that there seems to be a commonality on what's happening to Black and brown women when they enter into a clinical space, where in one sense we have a lot of these women receiving cesareans needlessly, or they're being tested. They're being drug tested involuntarily. So a lot is happening. I'm trying to understand how this is possible and how their rights are being violated in this way. And if there is data, test, like, how can they test without the consent, and what are these results?
Yeah.
That could speak to that.
Yeah. I want to say, just in case if anyone has similar questions, there's some hyperlinks in the document that I hope went to other research and information. But to your point around cesareans and how it can, the coercion can happen in like subtle ways, is one, it's important to understand we need OBGYNs. We also need midwives, but OBGYNs are trained surgeons. We have to understand that fundamentally, that's just really, really important. But the subtle ways in how this happens is that if an OB is overwhelmed, or if an OB wants to take a vacation, they might oftentimes tell someone that they need to have a cesarean, and they will not be honest and say, I want to go on vacation with my family at the end of November. And so therefore, so what happens is the unintended consequences that someone thinks that there's something innately wrong with their body. So if they wanted to have a vaginal birth, the autonomy was totally taken away from them. So those are some of the subtle ways in how it happens. We also have to be thinking about risk factors. They are important, but we also have to reframe how we understand risk factors and how we oftentimes put that onto Black and brown bodied people. And we really need to be a little bit more intentional. And so if we could work more in concert looking at the doulas, looking at midwives, looking at physicians, and having a full constellation of care, we would wholeheartedly see transformative change. From a personal vantage point, as someone who is a birth doula, I have seen clients who have been coerced into having a cesarean. And sometimes they are heavily scheduled way in advance, and they should not necessarily be scheduled unless it's for an emergency situation. Oftentimes what happens is that they find out that the OB needed or wanted to go on vacation or needed some time off. And so when you're trying to structure your time, you then go into setting dates so that you can control your time a little bit more. I'm sorry?
And the involuntary drug testing?
And the involuntary drug testing is, although there's this concept or this idea of universal drug testing, people are just not told that they're being drug tested, or it's very, very small, or it's in very subtle ways. And so you begin to get drug tested. You do not know. I was someone who was also drug tested, and I did not know until I actually went for my first COVID test, and the University of Maryland showed every single drug that I was tested for. And what I will say to you, and in that moment, the very first thing that happened to me was thinking, what did I do wrong? How did I show up? Why was I drug tested? And so that creates a further pipeline. We want to really ensure that people are well taken care of, but we do not want to use it as a barometer to see if they're going to be good parents or not. We want to see if we're giving them the adequate resources so that they can do the best to their ability.
Thank you.
Thank you.
Thank you. Delegate Hill.
And thank you for the work for the women and mothers here in Maryland, for the collective. Do you have, and if so, maybe it's in the links here, can you make the connections between the recommendations here, which are really extensive and well thought out, and the overarching issue of disparities in Black maternal health in that period around birth and the year after?
Mm-hmm. So like thinking about this and its connection to Black maternal health, yeah. I will also mention that we are one of the founding members with the Black Mamas Matter Alliance. And so this year actually will be starting 10 years of what is oftentimes celebrated as Black Maternal Health Week. And so through the years, what we have created is a full policy agenda. And so when we do send this back to you, you'll see we're not really duplicating anything. It's really about how can we be intentional about Maryland and also the other states. But the biggest part that I would say is that we have to be very, very intentional and explicit about saying what we mean and meaning what we say and moving into that. I would say personally, we oftentimes deal with a lot of paternalism with a lot of our colleagues who work in academic and other institutions and hospital settings. We have to work together. And oftentimes people see us as a nuisance as opposed to a collaborator. And so when we are really trying to, one, hold our lives and make sure that we are safe, we're also doing that for our community. So that would be one. I will also want to say, it is important to have anti-racist, implicit bias trainings, but there's also explicit racism and explicit bias. And so I have lots of colleagues that I engage with who tell me about all of the trainings that they have done while equally doing something extremely racist right in front of me, and or gatekeeping or keeping us from doing the type of work. So really for this work of us as the Maryland Black Perinatal Health and Reproductive Justice Collective was because we were not being heard or listened to when we are thinking about the care that we really need within this state and beyond. And so every single issue, really you'll see the high amount where Black and brown folks are being severely harmed in every single last one of these issues.
So I guess the question is, there are lots of different kinds of harm, right? And I can accept all of the recommendations in terms of better quality health. I'm trying to make the connection between that therefore translates to improved mortality rates, to improved morbidity rates. And that's what I'm asking, is there data that makes the connection that if we were to implement all these things, that disparity, the rates would go down, the disparity gap would close, and we'd have healthier pregnancies, healthier births, and more women, Black women, surviving beyond the first year after birth.
Yeah. I appreciate you reframing that for me to better understand. One, from the perinatal leave, when we're thinking about the heavy amounts of folks who never get time off, that's oftentimes Black and brown folks. So them never getting time, they have to go back to work within sometimes a week or 2 weeks, and your body hasn't even healed right? And so how when we're thinking about that kind of arc, when we're thinking around maternal mental health, we do not have the same amount of Black practitioners who are trained in perinatal mental health. And then oftentimes we dispose of folks within like the behavioral health context as opposed to meeting them exactly what we need or what they mean. Oftentimes that looks as though someone is not feeling great. Often what it also looks like is that in a system that doesn't already believe you, but also wants to criminalize you, when you say that you were sad or you were depressed, you oftentimes will withhold that from your physician because you don't want your baby taken away from you, right? And so what does it look like when someone is meeting you where you are that totally transforms that in so many ways?
So I know we're at time because I want to hear more about data.
Okay.
Than just a sense that would make things better. I want to know where that we've done it here and we showed these outcomes.
Yes.
Because a lot of it's logical. That doesn't mean it shows the data. Thank you.
Thank you very much. Delegate White Holland.
Thank you, Madam Chair. And very quickly, I appreciate you elevating the fact that we are seeing hurt and harm and trauma being inflicted here. When we're thinking about where it's taking place and how it is happening here, what does accountability look like? What can it look like? What should it look like? And what are the ways in which that we can ensure that, aside from the training, you know, as you mentioned, what are the other ways that we can better hold our institutions accountable to ensuring that we can make sure that people are not being harmed here?
Yeah. I appreciate you mentioning that. I would say one of the things that came out when we were talking about accountability is that people really struggled with that. And so I would really like to go back to the policy collective as a group and really challenge us to really start thinking about what does actual accountability look like? What does it feel like? What will we need in order to feel valued and listened to? And then, but not only listen to, how does it lead to a path of transformation? Actually seeing some type of change and transformation actually happening. I would like to come back to you all for that.
Thank you.
Thank you very much. Looking for any other lights. All right. I just have one question because I was looking back at our concerns around our high rate of cesareans, and that goes back to 2015. I think was when we originally started looking at that. And you had mentioned risk factors, but risk factors in Maryland are consistent with risk factors across the country, correct? Yeah. And when we look at the innovations that we have versus the outcomes, we are not seeing that sort of return that we would expect. So given the expertise that you bring to the table, can you just speak for our edification to the collaboration you have with the department, with the Maternal and Child Health Bureau, with the Office of Minority Health? What does that look like? What does that collaboration look like?
I think it needs to be extremely deepened. I think through the years, we have seen consistent siloing happening. There have been moments where we have been in partnership and then the partnership falters. I am no longer co-chair of the Maryland Maternal Health Improvement Task Force for over a year. That was a choice that I made. I brought amazing and wonderful people to the table as co-chair from a communal perspective, but what we consistently saw was every single time we were trying to put into our strategy and strategic plan something that would actually move to the speed of community, it was oftentimes changed. And so we really want to be a little bit more intentional with seeing where we're actually listened to and we're honored and our work is really being honored. Many of the people around this table they work for local health departments. They are also professors and scholars. They are OBGYNs. They are midwives. They are doulas. They are all of the things. And they're coming together for various common goals, but the main common goal is to ensure that we get to the type of transformative futures that we absolutely need. So I would like to see a lot of the relationship be more of a bridge, not using us through time and space when it's convenient, but it makes no sense that we are here consistently with the same data over and over again, where it's one moment if we say, well, if you would have listened to us 5, 10, 15 years ago, we definitely could have made some transformative change. And we totally honor that funding. But I would say for many of us, we don't have the same type of funding, but we have the same type of intentionality. And if we move at the speed of intentional relationship building, we'll actually see a different outcome.
Thank you very much. And I would just say that we had an earlier briefing on public health and how we're going to look at advancing and building and modernizing our public health. And I know we still have that panel in the room. So I hope that we will take this as an opportunity. Again, we have 70 days remaining, and there's a lot of work that can be done. I know that because we once wrote an entire bill between crossover and sine die. So with that, we will go ahead and conclude the briefing on our statewide maternal health and morbidity. And thank you very much for your time. Once again, for planning purposes, we'll be starting our hearings at 4, let's just say 4:10. It's 3:55 now.